Welcome back to another deep dive. Today, we are stepping directly into the shoes of a medical detective.
Which is honestly the best way to learn this material.
Exactly. I mean, imagine you're standing at the nurse's station in a really busy hospital.
Mm.
You aren't just looking at dry numbers on a printed page.
Right, you're looking at a stack of 15 clinical charts. And as our sources beautifully remind us, a chart is really a patient speaking to us silently, but meaningfully.
And our mission today is to analyze these cases in a strict, rapid-fire sequence. We'll be moving chronologically from case 6 right through to case 20 based on the provided clinical scripts.
You want to train your ear to hear the actual life or death story that's hiding behind those raw lab values.
Okay, let's unpack this. We're starting right at case 6.
Uh-huh.
You were handed the file for a 35-year-old male presenting with acute onset jaundice, nausea, and severe right upper quadrant pain.
A very classic presentation. But the labs...
Transaminases are just absolutely shocking. I mean, ALT is 1875 and AST is 1045.
And just for context, normal is around 40.
Right, so that indicates massive acute liver cell destruction. The viral markers come back positive for HBsAg and IgM anti-HBC, so we know we are dealing with acute hepatitis B.
But the danger isn't just in those high liver enzymes, is it? We have to look at what the liver is actually failing to do.
Which is synthesis.
That is the crucial distinction. The most critical number on this entire chart isn't the ALT, it is the prothrombin time, or PT, which is 19 seconds against a normal control of 13.
Wow.
The liver isn't just a filter, it's a manufacturing plant. It produces the proteins your blood needs to clot.
So that prolonged PT tells us the liver's synthetic function is actively failing.
Exactly. This isn't just severe inflammation. This is severe acute hepatitis B with impending liver failure.
So the immediate takeaway for you as the clinician is that this patient absolutely cannot go home.
Right.
They require immediate inpatient care. You need to start nucleoside analogs like entecavir or tenofovir.
To stop the viral replication, yeah.
And you also have to administer IV vitamin K to try and give the liver the raw materials to correct that clotting deficiency.
Plus, you have to constantly monitor for hepatic encephalopathy by checking ammonia levels.
And watch out for fatal hypoglycemia because a failing liver simply cannot maintain blood sugar reserve.
Exactly. Now, from failing liver, let's look at a completely different system in crisis. Case 7 gives us a 25-year-old male with a 3-day history of high-grade fever, severe headache, and neutral rigidity.
A stiff neck.
Right. In a young adult, that triad is a massive red flag for meningitis.
So you immediately order a lumbar puncture to check the cerebrospinal fluid, or CSF.
Yeah.
And the fluid comes out cloudy, which is never what you want to see.
Never.
The protein is sky high at 180, and the sugar is...
critically low, just 12.
Right, just 12. Normal CSF glucose is usually around 2/3 of your blood glucose, so a level of 12 means something is horribly wrong in that fluid.
What's fascinating here is the mechanism behind that low sugar. It's a phenomenon called hypoglycemia. Think of the spinal fluid as a closed, pristine ecosystem. When you see sugar plummet to 12, it's because the bacteria are treating the brain's glucose supply like an all-you-can-eat buffet.
And the labs confirm it. The presence of 90% neutrophils and a gram stain showing gram-positive Cauchy in pairs points straight to pneumococcal meningitis.
And in these cases, time equals neurons.
You cannot wait for further cultures. You have to administer immediate IV dexamethasone.
Ideally before or with the first antibiotic dose.
Because the goal is to reduce the inflammatory injury as the bacteria die off, right? Which lowers the risk of permanent hearing loss or neurological damage.
Yes. Then you hit the infection hard with empiric antibiotics, specifically ceftriaxone and vancomycin.
Okay, so we just saw an infection raging in a closed space.
Yeah.
Let's look at case 8, where a plumbing system gets physically blocked. We have a 60-year-old male with progressive jaundice, severe itching, dark urine, and pale stools for 3 weeks.
The severe itching, the pruritus, is a major clue here.
Right. The labs show a direct bilirubin of 14.6, and the alkaline phosphatase, or ALP, is massively elevated at 1300. But the viral markers are completely negative.
So this isn't hepatitis.
Not at all.
The symptoms paint a mechanical picture. Pale stools mean bile simply isn't reaching the intestine. Dark urine means the water-soluble conjugated bilirubin is backing up into the liver.
Going into the blood.
Exactly, and being filtered out by the kidneys. And just like in case 6, we have a prolonged PT of 19 seconds, but for a totally different reason.
Because vitamin K is a fat-soluble vitamin.
Yes. Without bile reaching the gut to break down fats, the vitamin K simply isn't being absorbed. This is obstructive jaundice.
And in an elderly patient with a progressive, painless course like this,
It is malignancy, like pancreatic cancer, until proven otherwise.
It's incredible how the exact same 19-second PT can mean two completely different disease processes depending on the context.
Context is everything in medicine.
Speaking of metabolic chaos, let's pivot to case 9. A 15-year-old patient presents with massive polyuria, peeing 3,800 milliliters a day,
That is a dangerous amount of fluid loss.
plus excessive thirst, weight loss, abdominal pain, and a very distinct fruity breath odor. The urine findings show sugar is heavily positive, ketones are heavily positive, and the pH is highly acidic at 4.9.
This is a classic textbook presentation of diabetic ketoacidosis, or DKA, resulting from new onset type 1 diabetes.
Because there's absolutely zero insulin, right?
Right, the cells are starving, the body panics and starts breaking down fat for energy, which creates those acidic ketones.
And the golden rule of treatment here is that fluids come before insulin.
I love the mnemonic for this. Just like the letter F comes before in the alphabet, fluids before insulin.
If you just give insulin right away, you shift water and potassium into the cells so rapidly that the already dehydrated patient could go into cardiovascular collapse.
You must give IV normal saline first to restore the circulating volume.
Before you start the insulin infusion to shut off that ketone production. Let's stick with the renal system for a moment, but look at a localized infection. Case 10 is a 24-year-old female with dysuria, increased urinary frequency, and suprapubic pain.
Very common presentation.
The urine analysis shows massive pyuria, 60-plus cells per high-power field, and motile bacteria. But if you look closely at this chart, it's what is missing that's the real clue.
Only a trace of albumin.
And absolutely no white blood cell casts.
The absence of those casts is the most critical piece of data. Casts only form inside the microscopic tubules of the kidneys. So their absence tells you the infection has not ascended into the upper urinary tract.
It's strictly confined to the bladder.
Yes, acute bacterial cystitis. You can treat this empirically with an antibiotic like nitrofurantoin while awaiting the formal urine culture results.
Now contrast that localized, quick-fix issue with a systemic one that builds up over years. Case 11 is a patient presenting with jaundice and severe abdominal distension, specifically ascites.
Let's look at the blood proteins.
The albumin is low at 2.9, but the globulin is high at 4.3.
If we connect this to the bigger picture, normally albumin is much higher than globulin. This reversed AG ratio is a classic hallmark of chronic liver disease.
Because the liver is so scarred, it can no longer synthesize enough albumin.
Exactly, which drops the osmotic pressure in the blood, causing fluid to leak out into the abdomen. That's the ascites. Furthermore, if you look at the enzymes, the AST is 250 and the ALT is 162.
When AST is significantly greater than ALT, it strongly points to alcoholic liver disease.
Treatment here revolves around severe salt restriction, absolute alcohol abstinence, and diuretics to manage the massive fluid buildup.
Sometimes the liver's functioning fine, but the blood itself is under attack. Let's look at case 12. A 30-year-old female presents with generalized weakness and easy bruisability for 2 months.
Okay.
Her blood work shows mild anemia, totally normal white blood cells, but her platelets are dangerously low at 50,000.
This is an isolated thrombocytopenia. In a young female with no other obvious causes or systemic illnesses, this is classic immune thrombocytopenia, or ITP.
Her own immune system is tagging her platelets for destruction in the spleen.
Crucially, you treat this by suppressing the immune system with corticosteroids like prednisolone.
And here's the trap for the unwary clinician. If you see low platelets and think, oh, I'll just give a platelet transfusion, you are actually making a huge mistake.
Platelet transfusions are strictly contraindicated here unless there is a life-threatening hemorrhage.
Giving her new platelets is like sending reinforcements directly into an ambush. Her immune system will just instantly destroy them too.
That autoimmune misfire is wild. But what about when the immune system overreacts to an invader, but it manifests in the wrong organ entirely? Case 13 gives us a 20-year-old male with a recurrent nocturnal cough, wheezing, and shortness of breath.
Clinically, if you listen to his lungs, it sounds exactly like asthma. You'd instinctively reach for an inhaler. But then you look at the blood count, and his eosinophils are at a massive 32%, giving an absolute eosinophil count of around 4,800.
That massive hypereosinophilia tells us this isn't just asthma. This is tropical pulmonary eosinophilia, or TPE.
It's a hypersensitivity reaction in the lungs.
But it's driven by a microscopic parasite infection in the lymphatic system, usually filariasis. Because the root cause is parasitic, a standard asthma inhaler won't cure it.
The gold standard treatment is a 21-day course of an antiparasitic drug called diethylcarbamazine, or DEC. Once you clear the parasite, the lung symptoms vanish.
It's incredible how a simple differential white blood cell count completely flips the diagnosis from a chronic lung disease to a curable parasitic infection.
Speaking of tricky presentations, let's look at case 14, a 22-year-old male with 3 days of high fever, severe body aches, and fatigue. It's so easy for a busy clinic to brush this off as just a viral fever or throw a generic antibiotic at it.
But look at the chart.
The total leukocyte count is actually low at 3,000 with leukopenia. The differential shows only 16% neutrophils and a massive 82% lymphocytes. His platelets, however, are totally normal.
High fever combined with a drop in white blood cells and a relative lymphocytosis points specifically toward either an acute viral fever or an enteric fever, which we commonly know as typhoid.
The normal platelets help steer us slightly away from early dengue.
Yes, though in endemic regions, dengue and malaria must still be ruled out. The main lesson here is restraint. Do not rush to antibiotics without evidence.
Investigate first with blood cultures or serology and support the patient with hydration in the meantime. But what if that viral pattern shows up in the nervous system? Case 15 features a 35-year-old male with a low-grade fever, headache, and this is the key word, confusion for 2 weeks.
They do a lumbar puncture.
Yes, the CSF is clear. It has 140 cells, 90% of which are lymphocytes. Protein is high at 112, but the glucose is totally normal at 65.
This brings us back to the golden rule of neuroinfections we discussed in case 7. Bacteria, TB, and fungi actively eat glucose, viruses do not.
So lymphocytes plus a completely normal sugar level strongly indicates a viral infection.
However, the patient has confusion. That means the infection isn't just in the meninges around the brain tissue itself is inflamed. This is meningoencephalitis.
Because herpes simplex virus, or HSV, can rapidly destroy the temporal lobes and be fatal if missed, you must start empiric IV acyclovir immediately while waiting for the definitive PCR results.
Delaying that acyclovir while waiting for a lab confirmation could cost the patient their memory or their life.
Let's move from an acute viral attack to a slow-burning cellular rebellion in case 16. A 45-year-old male presents with fatigue, weight loss, and a very specific dragging sensation in his left upper abdomen.
Which turns out to be massive splenomegaly.
Huge. And the total leukocyte count is off the charts at 140,000. There's a myeloid bulge, meaning a parade of white blood cells at every single stage of maturation is floating in the blood. But crucially, there are only 2% blasts, the most immature cells.
That low blast count is the most important data point. Blasts under 20% mean this is a chronic leukemia, specifically chronic myeloid leukemia or CML.
If the blasts were high, we'd be looking at an acute, rapidly fatal leukemia.
CML is actually one of the greatest success stories in modern oncology. By genetically testing for the Philadelphia chromosome, we find the BCR-ABL fusion gene.
And we can now target that specific genetic error with tyrosine kinase inhibitors like imatinib.
Patients taking this oral targeted therapy can go into deep remissions and live near normal lifespans.
It's amazing. We took a disease that used to be a death sentence and turned into a manageable chronic condition. Here's another blood anomaly in case 17 that looks like one thing but is actually another. A 25-year-old male with fatigue, palpitations, and moderate anemia with a hemoglobin of 7.
Okay, what do the indices show?
The MCV and MCH are low, indicating a microcytic hypochromic anemia. Usually, small, pale red blood cells scream iron deficiency. But his reticulocyte count is 10%, and there are target cells on his peripheral smear.
This raises an important question. If the bone marrow is truly lacking the raw material of iron, how on earth is it managing to pump out 10% reticulocytes, which are immature red blood cells?
It is an iron deficiency.
Exactly. The marrow is actually hyperactive because the red blood cells are being destroyed in the bloodstream through hemolysis. This specific pattern, especially with target cells, is a thalassemia syndrome.
If a doctor reflexively gives this patient iron supplements without checking a ferritin level first, it is actually dangerous and can cause severe toxic iron overload in their organs.
Let's keep pulling that thread of red blood cell destruction. Case 18 involves a 20-year-old male from a tropical region with a 5-day fever, yellow eyes, and dark urine.
His total bilirubin is elevated at 5.8, but it's mostly unconjugated at 4.7. Astonishingly, his liver enzymes, ALT, AST, and ALP, are completely normal.
So how can a patient be that jaundiced with perfectly normal liver enzymes?
Right.
Think of the liver as a processing factory. When the liver itself is inflamed or damaged, it leaks enzymes into the blood. Since his liver enzymes are completely normal, we know the factory is working perfectly.
It isn't inflamed, it is just being overwhelmed by massive deliveries of broken down red blood cells.
Yes, this is prehepatic jaundice caused by massive hemolysis. Given the high fever and the fact that he's from a tropical region, you must immediately do a blood smear to rule out malaria as the cause of this rapid blood destruction.
That's an overwhelmed factory. What about a physically damaged filter? Case 19 gives us a patient with severely reduced urine output, just 370 milliliters a day, and smoky or cola-colored urine.
The urine sediment shows heavy albumin, plenty of red blood cells, and crucially, red blood cell casts.
Those casts are the absolute smoking gun.
Red blood cell casts only form when red blood cells physically leak through a severely inflamed filter, the glomerulus, and get squeezed and molded inside the renal tubules.
So this means the diagnosis is acute glomerulonephritis or nephritic syndrome, likely post-streptococcal given the classic presentation.
The management here requires immense restraint. You must enforce strict fluid and salt restriction to prevent the patient from going into massive fluid overload and pulmonary edema.
Because their kidneys simply cannot excrete the water. So what does this all mean for our final chart? Which brings us to case 20, the silent, chronic counterpart to that damaged filter.
The patient again has reduced urine output, about 400 milliliters a day.
But the urine is completely clear, with no blood at all. We look at the specific gravity, and it is rigidly fixed at 1.01, and there are broadcasts present.
Wait, isn't 1.010 the exact specific gravity of blood plasma?
Yes, it is, and that is a tragedy for this patient. When urine-specific gravity is fixed at the exact same concentration as blood plasma, it means that kidneys have entirely lost their ability to actively concentrate or dilute urine.
They're acting as passive dead tubes.
A condition called isosthenuria. Furthermore, broadcasts only form in the dilated tubules of severely scarred, atrophied kidneys.
This isn't acute inflammation that might heal. This is end-stage chronic kidney disease, or CKD.
The patient requires severe fluid restriction, a low-protein and low-potassium diet, and you have to prepare them for an impending transition to dialysis.
Wow. We just ran through 15 incredibly diverse cases, from a liver failing to clot blood to a kidney that has become a passive tube.
It's a lot to take in. It is. And what stands out to you as you listen to this is how isolated numbers completely dictate life or death clinical decisions. I mean, a 19-second PT in our hepatitis patient, a 12 CSF glucose in meningitis, or a fixed 1.010 specific gravity in kidney failure.
These aren't just lab errors or statistical noise.
No, they are the literal language of a body in crisis.
If we connect this to the bigger picture, it leaves us with something profound to consider. All of these cases rely on single snapshots in time. A blood draw or a lumbar puncture taken at a specific hour on a specific day.
Completely static.
But imagine the future of medicine where continuous biometric monitoring makes the static printed chart obsolete. If we could watch a patient's transaminase spike or their specific gravity shift minute by minute in real time through wearable or implantable sensors,
We would see the trend instantly.
Exactly. How many of these life-threatening crises could we stop before the organ ever truly fails?
That is an incredible thought to end on, the shift from reacting to a static chart to predicting the crisis in real time. Thank you for joining us on this deep dive. Keep looking beneath the surface of the data, and we'll catch you on the next one.